give an exact FiO2 versus like an estimated.
Yep.
Like, how many.
And that's it. And so, why that's important is because these patients might have different breathing patterns, right? And so if you had a regular mask on and they're really huffing and puffing, they might entrain more room air. And so you couldn't, it would bring down your overall FiO2. Okay, so this, the way it's designed is it doesn't matter how they're breathing. This is always going to be able to deliver the precise FiO2. Okay, so why that's important again is because some of our patients, we don't want them to have too much FiO2, right? Or the doctor could just tell you, hey, I want this percentage, right? And you gotta figure it out. So COPD patients, you might see questions where this is involved. Because for your COPD patient, you usually do not want them to be on a high amount of FiO2. And so we want to guarantee that we can give them that low amount. Okay, so usually for your COPD patients, nasal cannulas, air entrainment masks. Okay. And then again, the one you guys have in your guys' kits, right? You have different colors. This is one where it's just designed to twist, and it's essentially like switching a color. Okay. You're still going to have a certain liter flow that you're going to have to set your flow meter at so you can deliver whatever FiO2 is associated with it. Okay. What else do you got?
As far as what we need to do?
Questions, yeah.
Oh,
Because if you want to like this, right, that's all this is doing is it's going to be entraining it the right amount of air based on the flow, and we can guarantee FiO2 coming out of this.
and that's why it's called fixed air. And what type of mask would you use with that again?
This is usually just like, where's your kit?
The non-rebreather or?
No, it's not non-rebreathing. It's
No?
just like a normal simple mask.
Oh, the simple mask, okay.
So the indication to use this would be basically a physician order requesting a specific percentage of FiO2.
Yeah, that's exactly what we can do. And then again, just the other ways you'll see like on the body exam, if they'll give you like a history of COPD or something. And they're trying to get you to think if we give them too much oxygen, they usually deteriorate, which is false. But
So then you would want to use something like.
So then just
air
the
treatment
simple
to
mask?
go at a lower FiO2
Okay.
weight, so you wouldn't over-oxygenate.
okay. And again, so this is a theory. There's a lot of science that says this is not true, but this is still what you hear at clinicals, still what you get tested on. But if you give a COPD patient too much oxygen, they die. They stop breathing. Okay, so there's no science behind that. Well, there's very little science that we've done for horrible research, but that's something like one of those little lies that everyone just starts saying and believing. So if you don't give your COPD patient oxygen and they need it, what's the outcome? What happens to their organs?
Start to shut down.
Yeah. So what's the trade-off? They stop breathing? Is that kind of why we're in school right now, so we can breathe for someone?
Mm-hmm.
Right? So don't be afraid to give a COPD patient oxygen. Okay? But for your board exam, like they want you to think about that theory. And so that would be another reason why you might see it on the test where this would be an option. And they're trying to give you that clue of the history of COPD and maybe their hypoxic drive is going to shut down. Okay, and so I guess to fully kind of grasp what I'm talking about is we normally breathe. Why does your brain say to breathe faster or slower?
Depending on what your organs need.
You said why does it, where's your question?
Yeah, so why, with your brain, all of you guys right now, what's setting your respiratory rate?
My coffee right now. My heart.
Heart, not your heart.
It could be like exercise.
Well, that's going to come into play.
Your, I forgot the word,
CO2
semiopathic.
and SaO2.
Okay, so you're throwing out some terms, good. So where do we get that PaO2 from?
You mean the hemoglobin?
No, so PaO2, we would find that on a blood gas. Okay, so ventilation, CO2, right, is what we use, what's telling our brain to breathe.
Sympathetic system, isn't it? The parasympathetic system is what's telling your body to breathe more, right?
Well, and just think,
I'm like,
right,
well, I was trying to say something. I couldn't think of what the word was for a minute.
I was telling you guys to remember normal ranges, right? So for CO2, I think I even gave you guys a little normal list or something on Canvas to start print that
Oh,
out and
yeah.
just keep it with you. But 35 to 45 is our normal range for CO2. So if it goes above 45, your brain's going to say, breathe faster, you're not getting enough CO2 out. Okay? And typically, if you're hyperventilating, there's usually a reason why. You wouldn't so much, in a perfect world, you wouldn't so much breathe really fast or your brain would tell you to slow down. But the idea is we breathe with CO2 levels. Okay? The idea with the COPD patient is that since they live with a chronic disease, that the CO2 levels, their lungs, right, they're not normal. So they're always going to be higher. And so that's not going to be what makes them breathe anymore, because their CO2's high, right?
Okay.
When we get high, our brain says breathe faster. Their lungs are damaged, so they live with their high all the time. So the theory is that their hypoxemia, right, them being low on oxygen, right? When you guys get low on oxygen, what do you guys do? What happens to your breathing? You start breathing faster, right? You're trying to get in more oxygen. So the idea is that the COPD patient uses that hypoxic drive to breathe. So if we take away the hypoxemia, they stop breathing.
So that's why I think I read in the book where it said that COPD patients do not need oxygen if its PaO2 is less than 50.
60.
Well, so I think their normal range that we're talking about with PaO2
It's like lower than us?
is down to 60 for a COPD.
Okay.
But we, like in general, we say like 50-50, 60-60 club. Okay? And so typically your COPD patients will have CO2s and oxygens in the 60s or the 50s. So just as long as you see that CO2 out of range, right, and low oxygen, you might want to start thinking COPD. Okay? It could be something else, right? But there's other things that you can look at. But just for our conversation, we don't want to get too far sidetracked. Hypoxic drive is what they worry about on your board exams, and that's why you might see this as well. Okay?
Is this one the one that's also called the Venturi mask?
Yep.
Okay, so that was confused.
Aaron treatment, Venturi mask.
It's just that we have the colors and then that one doesn't, everything's just in one piece.
Okay.
Everything in one piece. So, and again, depending where you guys end up going to clinicals and working, you'll have one of those. Okay? We actually got, I think we were using these for a while at Children's, and we had those for a while because we were trying some fancy high flow trach humidifier thing. I don't know. It was something that, I don't know if it's still doing it, but I know we had these right when I started to leave Children's. We started using these for something. Okay, you guys good with this one? Okay, so the majority of the time I want to talk about high flow. You guys will see a lot of patients on high flow. It's probably had some of the best outcomes for COVID patients, even compared to the ventilator. And so it's good for you guys to understand that. I want to start this off though. I see phones. I'm going to make you guys stop recording for a second.